Region 1B's May 2017 update training. The topic today is Medicare Advantage Plans. This is also the topic of the annual online recertification review. I'm zooming through the slides. But for those that may be their first time completing the ORS, the recertification review, I want to talk briefly about it. Here are the basics. The way you find your ORS is on ShipTools when you log in under the ORS tab. It is a multiple choice test. It's 38 questions this year, and it must be completed by all counselors that's certified before April 1st, 2016, before June 30th, and you are required to get a score of 80% or higher for it to be considered completed and passed. If you have taken the test and received a score lower than that, that's not a problem whatsoever. Map Inc. can reset your score and you can keep trying. But it is one of the requirements to stay active as a counselor in the MAP program, along with getting 60 hours of combined counseling, outreach, and general activity time every grant year, which is April 1st through March 31st, and also attending 2 update trainings yearly. So by attending this one, you're already halfway to the training requirement for this grant year. Once again, the ORS is located in ShipTools, and it must be complete by June 30th if you're a counselor that has certified before April 1st, 2016. If you have a question about whether you do need to take it, a good way to verify is logging into ShipTools and going to your ORS tab. If you do need to take it, a link to the test will be there, and if you do not, then it will not be there. So that's a good way to know. So moving on, the topic of this year, the topic changes every year. And this year it's on Medicare Advantage Plans, and this is nationally, it's on Medicare Advantage Plans. And so the goals of taking this recertification review this year is we want to be able to define what a Medicare Advantage or an MA plan is. We want to describe how they work, explain the eligibility requirements and how someone can enroll or disenroll if they so choose. We want them to be able to recall. I'm getting a call. I don't know if you can hear that beep, but onwards. We want individuals to be able to know their rights, their protections, and also the appeals process if they have a Medicare Advantage plan. And finally, we want to be able to summarize the different marketing guidelines put in place for those selling Medicare Advantage plans, and those are put in place by CMS. So we're going to start with Medicare Advantage Plans 101, the very basics. What is a Medicare Advantage plan? It is a health plan option. They are approved by Medicare, but they are run by private insurance companies. It is under the Medicare umbrella, so it's also called Medicare Part C, or you may see it referred to as a Medicare health plan. These plans, they take the place of having Part A and Part B. So they cover the Medicare covered benefits that A and B would cover, but it's that individuals are instead receiving their insurance benefits through a plan that's run by a private insurance company. Medicare Advantage plans often also cover Part D, prescription drug coverage, and they also sometimes cover extra benefits that Medicare, original Medicare, does not cover, like vision, dental, and hearing services. So once again, Medicare pays the private insurance plans for their members' expected health care, and then the plans provide the benefits. And Medicare pays the plans monthly, even if the member does not use the service. So every month the plans, they get money from Medicare just because a Medicare beneficiary is enrolled in their plan. So how do they work? As we've discussed, beneficiaries receive all Part A and Part B services through the Medicare Advantage plan. Many plans also include Part D, prescription drug coverage, and you may see the acronym for that is MA-PD. And then additionally, some Medicare Advantage plans cover vision and dental. So if someone has original Medicare and they're considering switching to a Medicare Advantage plan, or they're new to Medicare and they're deciding which option is best for them, what is the same between both of those experiences, having original Medicare or having a Medicare Advantage plan? What is the same is they're both beneficiaries of either option are in the Medicare program. They have the same rights and protections under Medicare, and they also all pay that monthly Part B premium unless they have Medicaid or in a Medicare savings program, and that is paid for them. So once again, the original having Part C or a Medicaid Advantage plan, it's in the place of having original Medicare, Part A and Part B. Now, what is different between the experience of having a Medicare Advantage plan and having original Medicare? Beneficiaries in some Medicare Advantage plans, like HMO plans, which we'll talk about more in depth later, they may only be able to use in-network doctors and hospitals, and they're going to save the most money if they're accessing services within the plan's network. This differs from original Medicare, where beneficiaries can go to any provider and get Medicare to pay for it, provided that the provider accepts Medicare. Medicare plans also may not follow the same rules for co-insurance and co-payments and deductibles. For Part A and Part B, if someone has original Medicare, the way the co-insurance and co-payments and deductibles work is standardized. Like for Part B, the 80% and 20% split with the 20% co-insurance or co-payment. This may not necessarily hold true in all Medicare Advantage plans. Each plan sets the rules in terms of co-insurance, co-payments, and deductibles, and it would be up to the beneficiary to look at the plan policies before enrolling to understand what that must be. A note for those working with beneficiaries that are dual eligible and who also qualify for Medicaid. Some Medicare Advantage plans, and this is another difference, they charge, everyone pays the Part B premium, and some Medicare Advantage plans, they charge an additional premium amount. And the beneficiary would be expected to pay that. They would pay that to the plan directly. But for those working with beneficiaries that have both Medicaid and Medicare, even if they have both of those, they may also still have to pay that additional premium if they're enrolled in a Medicare Advantage plan that has a premium that is above the standard Part B premium. So I'll repeat that because I think I got a little tangled up there. But some Medicare Advantage plans, they charge a premium amount that's higher than the standard Part B premium, and beneficiaries are required to pay that. This is true for beneficiaries receiving Medicare that are in Medicare savings programs too. That difference between the Part B premium and what the plan is charging, if they're enrolled, they would be responsible for paying that, with the exception of some QIMBY beneficiaries will not have to, and that is a state-by-state policy. So I don't know if that comes up a lot. I think many beneficiaries that are dual eligible are not necessarily enrolled in Medicare Advantage plans that are charging higher premiums than the Part B premium, but if you do see that, know that they may be responsible for that additional cost. So enrollment, who can join a Medicare Advantage plan? To be eligible, they have to be enrolled in Part A and Part B. The beneficiary has to live in the plan's service area, so there are geographic restrictions. They cannot be incarcerated. And in most cases, although there are exceptions, they cannot have end-stage renal disease. Outside of that, plans must allow new members to join unless the plan has hit a CMS-approved capacity limit or have been issued an enrollment sanction by CMS. And I will talk a little bit more about the exception with end-stage renal disease in case you're working with a beneficiary that has this, that is considering a Medicare Advantage plan. The exception that would allow someone with ESRD to join a Medicare Advantage plan is if they are in a plan before they have Medicare, they're in a plan, and the Medicare Advantage plan they want to switch to is with the same parent organization. So for example, they have an employee-sponsored plan by Blue Cross Blue Shield, and they would like to go into a Medicare Advantage plan also by Blue Cross Blue Shield. If there is no break in coverage and the beneficiary meets the enrollment requirements of the Medicare Advantage plan, then it's possible that they would be able to get this plan. Also of note, in relation to those with ESRD and Medicare Advantage plans, a person who has received a kidney transplant or no longer requires a regular course of dialysis treatment is not considered to have ESRD for purposes of Medicare eligibility. So they would not be blocked from joining a Medicare Advantage plan if that is their situation. To enroll, which is another important thing, how can someone learn more about the specifics of the Medicare Advantage plans? And they can enroll. One good way is going to Medicare.gov and using the Plan Finder tool. There's a link called Compare Drug and Health Plans. That's where they would go. And through the Plan Finder tool, they're going to find specific information about the plan and the contact information for the Medicare Advantage plans themselves. Another thing a beneficiary can do to learn more and enroll is calling 1-800-MEDICARE. When can somebody enroll? Talking more about enrollment in Medicare Advantage plans. So when can they enroll, or they can switch to another Medicare Advantage plan? They can do this during their initial enrollment period. That is the 7-month period when they first become eligible for Medicare. So for example, if someone is receiving Medicare at 65, the initial enrollment period begins 3 months before their birthday, includes their birthday month, and then continues for 3 months after. For those getting Medicare due to disability, the initial enrollment period starts 3 months before the 25th month of disability, includes that 25th month, and then continues 3 months after the 25th month. Another time individuals can enroll, and I think we're all very aware of this, is the annual open enrollment period. This is October 15th through December 7th each year. If somebody enrolls in a Medicare Advantage plan or switches during open enrollment, that coverage begins January 1st. And they can also enroll or switch if they have a special enrollment period, and we're going to talk about that on the next slide. So a special enrollment period is a length of time where, for special circumstances, someone is able to make a switch in their insurance. Some common reasons is that the individual moves out of the Medicare Advantage plan service area. Then they would get a special enrollment to find a plan that's available in their new area. Another common reason is if they qualify, if they have Medicaid, that includes the Medicare Savings Programs, or they qualify for extra help. If they have these programs, they actually have a continuous special enrollment period, and they are able to switch or enroll in a Medicare Advantage plan at any time. Other reasons for special enrollment periods, not continuous ones, but one-time, time-dated ones, is if they lose their extra help status, if they leave or lose employer or union coverage, if they're making a change that they're entering, they currently live at or leave a long-term care facility, and if they want to switch to a plan that has a 5-star rating. I also want to remind everyone that if they're in a Medicare Advantage plan and the plan stops participating in Medicare, they'll also have a special enrollment period. They'll be able to switch to another Medicare Advantage plan or enroll in original Medicare. So speaking more about this 5-star special enrollment period, this is a special enrollment that is available once per year. Individuals have the option to enroll once per year between December 8th and November 30th, so except for that 1 week, they can claim this, and they're able to switch to a plan that has a 5-star rating. CMS rates the different Medicare Advantage plans. They also do this with prescription drug plans for Part D based on customer service, complaints, member experience, safety ratings, and also the accuracy of the drug pricing. So they're trying to gauge the customer experience being enrolled in these plans. They give a rating that comes out every October, and then they become effective January 1st. So if someone wants to switch to a plan that has a 5-star rating, or they want to switch to a plan that has a 5-star rating, so they can only switch to plans that have that rating, then they're able to do that. They can do this once per year. A warning, though, that if they have a Medicare Advantage plan that includes prescription coverage, so Parts A, B, and D, taking care of those benefits for them, and they choose through this special enrollment to switch to a plan, a Medicare Advantage plan that does not have prescription drug coverage, then they will be without drug coverage until the next open enrollment period or the next time they qualify for a special enrollment period, and they will also likely have to pay a Part D penalty. So if someone is considering that switch, it's good to make sure that they are continuing to have prescription drug coverage. Another similar special enrollment period linked to the ratings that CMS provides is the low performing plan SEP. This is also once a year an option to switch from a plan if a beneficiary is currently in a Medicare Advantage plan that has less than a 3-star rating and they've had that subpar rating for at least the last 3 years, then they can use a special enrollment period once a year to switch to a plan that has 3, 4, or 5 stars. Once again, the Plan Finder tool on Medicare.gov is the place to look to see the CMS ratings, to see specific information about the plans, what plans are available in the beneficiary's area. The Medicare.gov Plan Finder tool can hook you up. Now, disenrollment. How does one leave a Medicare Advantage plan? So if someone would like to disenroll and return to original Medicare, provided they're able to do it, so it's their initial enrollment period, the open enrollment period, or special enrollment period, they can make the request directly to the Medicare Advantage plan itself or call 1-800-MEDICARE. And then coverage usually begins the first of the month after the change is made. So when are the times that this can happen? There is an annual time for those with Medicare Advantage plans and open enrollment period to switch back to original Medicare. It's January 1st through February 14th every year. And this window, it can only be used to switch from Medicare Advantage back to original Medicare. This is not a time where someone can switch to another Medicare Advantage plan, only back to original Medicare. But if they switch to an original Medicare, they also then have a chance to join a prescription drug plan to ensure that they continue to have drug coverage. Another special enrollment related to this that I want to talk about is if an individual signs up for a Medicare Advantage plan when they're first eligible for Medicare, or perhaps they switch from original Medicare to a Medicare Advantage plan for the first time, so the first time they're trying out a Medicare Advantage plan. If they are unhappy, unsatisfied for whatever reason, they want to switch back to original Medicare, and they do this within the first 12 months of signing up for that Medicare Advantage plan, during that 12-month window, they are also able to do this, to go back to original Medicare. Once again, that's only after the first time that they've enrolled in a Medicare Advantage plan, and if they've stayed in their Medicare Advantage plan for multiple years, after the 12 months, that special enrollment period no longer exists. And a reminder that anytime someone enrolls in a new Medicare Advantage plan or in a prescription drug plan, it automatically disenrolls you from your previous plan. Related to this 12-month window, the special enrollment period, the 12 months after someone joins a Medicare Advantage for the first time, this also can affect their Medigap guaranteed issue rights period. So when beneficiaries first become eligible for Medicare, when they turn 65, or if they have Medicare due to disability, then when they first turn 65, they have a guaranteed right to buy Medigap for a period of 6 months. And this is important because during this time, the Medigap plan, so this is Medicare Supplement Plan, must accept new members, and they're not allowed to medically underwrite the cost. So for beneficiaries that join a Medicare Advantage plan when they're first eligible for Medicare, or they've switched to a Medicare Advantage plan from original Medicare, and then they switch back within that 12 months, they are still entitled to that guaranteed right to buy Medigap. For those that may have previously had original Medicare and then went to Medicare Advantage, so if they previously had a Medigap plan in tandem with their original Medicare care, then they may be able to get the plan back if they switch back from the Medicare Advantage plan within 12 months, provided that the company still sells it. If the plan is no longer available, they have a guaranteed right period to buy another plan. And if someone joins a Medicare Advantage plan when they're first Medicare eligible and stays for many years, they forfeit their right to that guaranteed rights period for buying Medigap. So now I want to talk more about the types of plans. There's 6 types of Medicare Advantage plans. A popular one is the HMO, the Health Maintenance Organization Plan, and I think many are familiar with this model because it's used for non-Medicare plans as well. A defining feature of HMOs is that there is a plan network, and beneficiaries can only receive care from doctors and hospitals that are in this network. Of course, with everything, there are exceptions to this, and that includes if a beneficiary has to receive emergency care, out-of-area urgent care, or out-of-area dialysis. If they have to receive that from an out-of-network provider, that is often still covered by an HMO plan, but other than that, they have to stay in network to have insurance cover the cost. And this is true even for things that original Medicare normally covers, like flu shots. If someone gets a flu shot out of network and they have an HMO Medicare Advantage plan, their plan will not cover that cost. Other things to know about HMOs, another defining feature is that they need to choose a primary care provider, physician, and then if they want to go to a specialist, they need to get referrals from their primary physician or PCP. And it's also important to note that that primary doctor, if their doctor leaves the plan, that does not usually grant them a special enrollment period to change. They will still have to stay on the Medicare Advantage plan until the next open enrollment period or the next special enrollment period. Next, it's the HMO Point of Service. This is similar to HMO plans, but for these plans, beneficiaries may be able to go and get services out of network at some point, but usually it's for a higher cost. The beneficiaries certainly save the most money if they're going and getting services in network. HMO plans also, both Point of Service and regular HMO plans, note that they often, not always, come with prescription drug coverage, and they sometimes can have those extra benefits like vision, dental, and hearing services wrapped into it. And as we talked about before, some HMO plans charge a premium higher than the Part B premium, which would be the beneficiary's responsibility to pay, and they pay that to the plan. Next, I think another most popular of the Medicare Advantage plans is the PPO, Preferred Provider Organization Plans. Unlike HMO, those that have a PPO Medicare Advantage plan, they are able to see providers that are out of their plan's network and receive some level of coverage. However, it is likely more expensive than if they went to someone that was in network. So it's more expensive, but they may receive some level of coverage both in and outside of network. They do not have a primary care provider, unlike with an HMO plan, and they do not need to get referrals to see specialists. Like HMO and PPO plans often have prescription drug coverage as part of it, but not all. The beneficiary will have to go through the plan finder or other means, talk to the plan, and see what their policy is about that. Next, we get to special needs plans. There's 3 main types: chronic condition SNPs, institutional SNPs, and dual eligible SNPs. And these are designed to meet the needs of beneficiaries that have a specific condition. And the plans are specialized in order to be able to best meet their needs. For all S&Ps, prescription drug coverage is required. So all S&Ps come with prescription drug coverage. So talking more about the specific S&Ps, first, the S&P or C S&Ps for chronic conditions, and these are plans that are specialized for those. There's one specialized for various conditions, including but not limited to cancer, autoimmune disorders, alcohol, drug dependence, heart failure, dementia, diabetes, end-stage renal disease, HIV and AIDS, stroke, and more. What makes S&Ps unique is they will include doctors in their plan network that specializes in treating the condition. They will also likely have formularies that include the drugs that are often used to treat the condition in question. So it's just specialized for beneficiaries that have a certain chronic health condition. The next, the I-S&Ps, institutional S&Ps, these are particularly for individuals who live in an institution like a nursing home, so it's best suited for their needs. And finally, dual eligible S&Ps, D S&Ps, and these are specifically for beneficiaries that have both Medicare and Medicaid. The S&P plans, they administer both Medicare and Medicaid benefits. The plan administers both, so it can simplify the beneficiary's insurance situation. They do require referrals to see a specialist, and they also do not require beneficiaries to pay additional. They're not going to have an additional premium or cost-sharing amount. The beneficiary should not have to cost share or pay co-pays or co-insurance. That is a characteristic of the dual eligible S&Ps for those that have both Medicare and Medicaid. Next, we're in the 5 of 6 plans. It's the PFFS plans, private fee-for-service plans. Beneficiaries are not restricted to a network in these plans, but they are going to pay the least for providers that are in the plan's network. They do not require beneficiaries to have a primary care provider or get a referral if they want to see a specialist. The PFFS plans sometimes cover prescription drugs, and if they don't cover it, beneficiaries can join a Part D plan to supplement it, and the plan decides how much one pays for the services. And it's important that beneficiaries that have these plans confirm with their medical providers each time they receive a service that the provider agrees to treat them under a plan and that they accept the payment terms. So even if they've seen them before, based on the way the plan works, they're going to want to confirm this with the provider each time they receive service. Finally, there's Medicare Savings Accounts, or MSAs. These plans have two parts. There's a high deductible health plan and then also a Medicare Savings Account for that a beneficiary can use to pay for qualified health costs. So every year the plan deposits money, a fixed amount, into this medical savings account, and it's used for services that are not covered, and it can be used for services that are traditionally covered by Medicare and also not. Costs associated with Medicare Part A and B, so costs for services that are covered under Medicare are the only ones that count towards meeting the deductible of the health plan, and the beneficiary must meet the deductible before the plan starts covering any other services. So once again, it's a health plan with a high deductible that beneficiaries have to pay before the insurance kicks in, and then also a medical savings account that the plan deposits a fixed amount of money to every year, and beneficiary can access the funds of this account to pay for qualified health costs, and qualified health costs can also include things that normally is not covered by Medicare, like vision, dental, and hearing. It's important to note that beneficiaries with these plans cannot deposit their own funds into the medical savings account. It's only the plan that is depositing. If a beneficiary has this plan and they run out of funds in their medical savings account, then they would pay out of pocket until the next deposit. Money left over in medical savings accounts at the end of the year rolls over. And it's also important to note that beneficiaries that have these plans have to file a special form with their taxes. Many are ineligible to get these plans if they have TRICARE, VA benefits, federal employee benefits, if they have end-stage renal disease or receive hospice care, they live outside of the U.S. for more than 183 days a year, or have coverage like a Medigap that would cover the plan deductible, then they would not be eligible to join this type of plan. These plans do not offer prescription drug coverage, and they do not have provider networks. So now that we know about all the different types of plans, I want to talk a little about network changes. For plans that have provider networks, it's important to know that the plan and providers can change networks at any time. So what providers are considered in network can change, and this is not usually a basis for a special enrollment period. However, there are safeguards in place to protect beneficiaries, and this is what plans are required to do if they're making changes to their provider networks. They have to protect enrollees from interruptions in care. So if the change results in an inability for members to access medically necessary services, then the plan needs to do something to make sure the members are getting those services. So if a provider that offers a specific unique service leaves their network, they need to add providers that can also provide that service so that need is met. They're also required to notify enrollees who see the affected providers, and they're supposed to do this through written notification at least 30 days in advance of termination, and the plan must also suggest alternative providers so that the beneficiary doesn't have to do all of that research themselves. Occasionally, network changes can result in a special enrollment period, but CMS determines this on a case-by-case basis. Talking more about guaranteed rights and protections, as we discussed in the beginning of the presentation, those that have original Medicare and those that have Medicare Advantage plans, they all have the same rights and protections under Medicare because they're all Medicare beneficiaries. These guaranteed rights include the ability to access needed healthcare services, that they receive easy to understand information about their insurance situation, and that their personal medical information is kept private. Those that have Medicare Advantage plans have additional rights. These rights are that they get a choice of their healthcare providers, they get access to their healthcare providers, they know how their doctors are paid through the plan, they know and that there exists a fair, efficient, and timely appeals process and grievance process, which we'll talk more about very soon, that they know their coverage and payment information before they receive their service, so the plan's providing what they may need to pay, what's being covered before they receive the service, and also that the plan's protecting their personal health information. So speaking more about appeals, if a plan will not pay for a service a beneficiary requests, if they do not allow a service, or if they stop or reduce the course of treatment midway through, then a enrollee in that plan, they can file an appeal. If the beneficiary feels that the not having the service or the reduction in service is seriously harming them, then they can request an expedited appeal decision from the plan within 72 hours. So an appeal can go as quick as 72 hours. If it's expedited, it can also be extended up to 14 days before the plan gets back to the beneficiary on their appeal decision, and either the beneficiary and the plan can request that 14 days time for purposes of gathering more information. Each plan is going to have their own process and instructions for how to file an appeal or grievance, so it's up to the beneficiary to look at their plan membership material. So talking more about the appeals process, this is the order that an appeal can ascend. It may get kicked up the chain. So there's five levels of appeal. It starts with the initial determination. So this is when the plan either may reduce the service or not allow the service, and the beneficiary is informed. If they want to appeal, then they put in the appeal and the plan issues a reconsideration. So they look at the appeal and then they make their second decision. If a beneficiary is unhappy with what the plan says when they've reconsidered, then they can take the appeal to an independent review entity or an IRE. If they're unhappy with that decision, they can then go to an administrative law judge. If they want to pursue this, the administrative law judge, their claim must meet a minimum dollar amount. It's updated every year, but in 2016 it was $150. If they're unhappy with that decision and they want to continue the appeal, next it's to the Medicare Appeals Council. There is a question on the ORS test that talks about the MAC, and it calls it the Medicare Administrative Council, and I'm not sure why it does that because they're called the Medicare Appeals Council. Finally, if they want to appeal again after it going through the Medicare Appeals Council, and this is only for claims that are changes yearly, but $1,500 or more in 2016, they can go to a federal court and have them review the case. It's important that beneficiaries know about these options, but they think about the time frame and they think about the dollar amount of their claim, because they may have to stop at an independent review entity appeal or a Medicare Appeals Council appeal based on the amount their claim is worth. Our final topic of this training, also included on the ORS test, I realize I failed to mention, but at the bottom right corner of these slides, which I can also send out after this training, it says questions, and this one doesn't, but other ones have, and it has a number. This is the questions on this year's ORS that correlate to the information on the slide. So it's sort of little hints. If you're stumped on a question, you should look for it in this presentation, and the information on the slide should help you answer the question. So finally, I want to talk about marketing materials. There are many rules that CMS puts on those that are selling Medicare Advantage and also prescription drug plans. CMS reviews all plans' marketing materials for Medicare Advantage plans, and they also require plans to use standardized marketing material language and format for some documents, such as the annual notice of change and evidence of change forms. Marketing for the upcoming year cannot occur before October 1st, so they put some time guidelines on it. And they also require plans to communicate, as that's one of the guaranteed rights, to have clear communication from the plan. So all MA plans have to send out to their enrollees a standardized annual notice of change, an evidence of coverage form. They have to send out information on the formulary if the plan has prescription drug coverage, what drugs are covered, to what extent. And they also have to send the beneficiaries the directories of pharmacies and providers that are in the plan's network. And a lot of this information is usually sent out in an annual membership package on September 30th of each year. Additionally, CMS has put other rules in place that the plans themselves are in charge of training their employees and monitoring to make sure they're in compliance. And then CMS, they audit and monitor as well these rules, but it is the first responsibility to make sure these rules are being followed is with the Medicare Advantage plan themselves. So more rules that they need to follow when telling potential enrollees about the Medicare Advantage plans. They can offer gifts to potential enrollees, but they have to be nominal, and they have to be $15 or less in value. They cannot be cash or monetary rebates, like a Visa card, but they can be gift cards. They're also not allowed to give a potential enrollee more than $50 per year to entice them to learn more about the Medicare Advantage plan. Plans also cannot provide meals during promotional events about the plan. They can provide snacks, but they can't provide or subsidize meals. They're also not allowed to give potential enrollees calls, send emails, or go door to door if it's unsolicited, unless they have the express permission of the potential enrollee. However, this does not apply to mail and print media. Plans are allowed to send mail and print media to enrollees regardless of if they've received permission. Medicare Advantage plans also cannot solicit Medicare beneficiaries in common areas like sidewalks, parking lots, hallways, and this with the exception of common areas in healthcare facilities. But while plans can talk about the Medicare Advantage plans in healthcare common areas, they can't talk about it in places where services are provided. So like in a hospital, they can't go into someone's room, they can't go into waiting rooms. Anywhere that services and care is being provided, they should not be selling or promoting their Medicare Advantage plan. Finally, CMS also requires that plan employees specify the scope of appointments with potential enrollees if they're going to meet with them one-on-one to talk about the Medicare Advantage plan. At least 48 hours prior to the meeting, they have to identify what the scope of the meeting is. So if they're talking about one product, they can't then come and talk about 3 different products. So it's a safeguard in place that they're not bombarded with pitches for other products or other plans, that the employee has to be intentional and they have to be very upfront about this is what they're going to talk about. Now, if you're wondering why I'm telling you all of these rules and why SHIP and MAP feels very important that you know these, it's because we're really always looking out for the well-being of beneficiaries. We want to make sure they're not experiencing any fraud, abuse, or neglect, so that they're not being pushed into a plan in any type of unsavory way. So these are safeguards to protect beneficiaries, ensure them that they have the decision and they're not going to feel pressured, but they have the decision to make their own health care options and find the best health insurance option for them under the Medicare umbrella. Finally, talking about Medicare Advantage Plan marketing rules, I want to touch on the rules for educational events. So plans often put on educational events for those that are prospective plan enrollees. These events are supposed to talk about health and well-being services provided, but they're not supposed to specifically be pitching a plan. So at these events, they cannot discuss plan-specific premiums or benefits. They cannot distribute scope of appointment forms or enrollment forms for a Medicare Advantage plan. And they cannot set up individual sales appointments or gain permission for that outbound call. So these are things that should not be happening if a private insurance plan is putting on an educational event for prospective enrollees. They should not then turn it into a sales pitch for their particular Medicare Advantage plan. So that's all I have, and the information in this training should cover all of the questions on the ORS, which is available in SHIP Tools, the annual recertification review for counselors. If you have additional questions about the test, about Medicare Advantage plans, you can contact me or you can contact your site coordinator. You'll also have time now, and I hope you can use the next hour if you'd like to take the ORS test. There's paper tests available if you're in one of our satellite trainings, or you can go on to SHIP Tools and look at the test and take it online. Even if you take it on paper, it's been noted, I know this has worked differently in the past, you still have to go and log into SHIP Tools and complete it online for it to count for MAP Inc. So I can take questions on this. If you have questions, you can raise your hand and I can unmute you. Before I do that, I want to have a quick reminder that the Area Agency on Aging, we just put in a nearly automatic email and encryption tool on all emails that we send to those in external organizations. So unless you have a AAA1B email address, you're an external party. And unless our staff, Lisa, Bev, Megan, Margina, and I, do not write no encrypt in brackets in the subject line, then the email will be sent encrypted to you. What does this mean? It means to access the email, you have to create a Proofpoint account. Proofpoint is the company that provides the email encryption for us. You have to create the account and you have to sign in. And then you can use the same account once you have it, save the information because you'll use it for future emails for us. The reason our agency does this is to stay in compliance with HIPAA, although MAP is not required to be HIPAA compliant. Almost every other department in our agency is, so that's why we're doing it. And generally we talk about beneficiaries too. If there's personally identifiable information or personal health information, we want to make sure it's sent securely. So in those situations, especially if we're talking about beneficiaries, we will be sending encrypted emails to you that you'll have to log in to access. For things that don't have that information, we will do our best to remember to put no encrypt in the subject line to save you that extra step. But we want to let you know that that's happening. And if you get an email from us that says Proofpoint, log in, that's what it is, and we appreciate your cooperation and patience with that. So please let me or your site coordinators know once again if you have questions for that. So I don't see any hands raised, so I'm going to assume there's no additional questions. Thank you for joining me on this webinar. Our next update training in June, it differs based on some counties, but the live one, it's Thursday, it's June 22nd. I'm 90% sure that's the date, but it's that third Thursday. Or maybe it's the fourth. I'm giving you all sorts of information, but I'm 80% sure it's June 22nd. It's on your update training schedule that I sent out with the reminder email this week that has all of our training, our update training for dates for our region from now and through October, which is for 2017 because we do not do update trainings in November and in December. The next one, June 22nd, Linda Kushner, who is the Medicaid specialist at MAP Inc., will be speaking on issues related to Medicaid and Medicare dual eligible beneficiaries. She's not completely cemented the topic of her talk, so if there's something related to Medicaid you really want to learn more about, please email me. My email is lestinson, L-E-S-T-E-N-S-O-N, at aaa1b.com, and let me know, and hopefully she can incorporate that in the training. So there's a webinar on that day, and she's also speaking live in Oakland, in our Oakland office in Southfield. Everyone's welcome to join, and then we'll also have some satellite sites as well. So thank you again for joining. I'll leave you to taking the test and talking if you were with others, with your crew, and we will speak soon.